Hi everyone. In this video, we'll discuss about subarachnoid hemorrhage, one of the most common causes of neurosurgical emergencies. In this video, we'll discuss about what is SAH, what are its causes, how to diagnose it, how to manage this one. So, subarachnoid hemorrhage is accumulation of the bleeding in the subarachnoid space, which is present between the arachnoid and pia. Normally, this subarachnoid space is filled with CSF in which arteries are bathing. So, what are the causes of subarachnoid hemorrhage? So, they are broadly divided into trauma and spontaneous. Trauma is the most common cause of subarachnoid hemorrhage overall. Coming to spontaneous, they are due to rupture of the aneurysms or rupture of the AVMs. AVMs are arteriovenous malformations. They are entangled abnormal blood vessels. They bleed. So what are the aneurysm? Aneurysm is abnormal focal dilatation of the vessel wall due to weakness of the vessel wall. It is called berry aneurysm because they look like berry. They are found in the circle of Willis, which is a ring-like arterial structure. It connects the majority of arteries at the base of the brain and supplies the collateral supply to the brain if the one artery is blocked. So in the circle of Willis, the most common site is anterior communicating artery, which connects both anterior cerebral arteries. Other sites are internal carotid artery and posterior communicating arteries, middle cerebral arteries, and posterior circulation aneurysms like basilar type aneurysms. So what are the risk factors? The two most important modifiable risk factors are hypertension and smoking. Other non-modifiable risk factors are family history of aneurysm and adult dominant polycystic kidney disease. Familial history, they have more increased incidence of aneurysms. So how do they present? One of the classical presentation of the SAH subarachnoid hemorrhage is thunderclap headache. They describe this as the worst headache of their entire life. They have not felt this much of severe headache in their life. So it is sudden, severe onset associated with neck stiffness because of the irritation of the meninges called meningism. Meningism. And some have cranial palsy also. So what is sentinel headache? Sentinel headache is an important early sign of aneurysm rupture. It is like warning leak before the major rupture. This happens some hours to days before the major rupture. So we need to investigate extensively the location of the underlying aneurysm if there is there, so that we can address it aggressively. So sentinel headache is warning headache. It is an important early sign. So how do they present? They present with we discussed headache, vomiting are there. Now they have photophobia, means they have the fear of lights, the vomiting, altered consciousness. They some present with focal neurological deficits like hemiparesis, like all those clinical signs. So there are two grading systems. One is Hunt and Hess. It is a clinical grading system based on the status of the neurological examination. It is graded from 1 to 5. 1 is patient is conscious with mild headache. 5 is very severe, either patient comatose or maybe disabetic posture, depending upon severity. So one has best outcome, 5 has very poor outcome. Other grading system is called Fisher grade. This is based on CT scan findings. The importance of this Fisher grade is to predict vasospasm. So it is divided into 1 to 4 grades. One is the minimal SAH, minimal amount of blood on the CT scan. to 4 is very thick bleed, including intraventricular bleed. So the importance is to predict vasospasm. Vasospasm is one of the complications of subarachnoid hemorrhage. So if the grading is high, means if the grade is 4, very thick SAH with intraventricular bleed has very poor prognosis. Grade 1 is very thin blood on the CT has very good prognosis. So Hunt and Hess is clinical grading and Fisher is CT scan based grading. This is to prognosticate, to determine the outcome and to guide the management of the case. These two grades are very important. So how do we diagnose SAH? The gold standard investigation is plain CT scan or non-contrast CT scan. If it is done within 6 hours of the bleed, the sensitivity is 98%. So sometimes the clinical suspicion is very high, but CT scan is negative. Then what should we do? We need to do lumbar puncture. So if you have doubt of SAH, but CT scan is negative, means there is no SAH, no bleed, then go for lumbar puncture. If the SAH is there, we should know where is the site of the aneurysm and the neck of aneurysm. For that, we need to take CT angiogram or MR angiogram. Of this, CT angiogram is best. Other is DSA, digital subtraction angiography, is invasive angiogram. This is also used to diagnose aneurysms and hemodynamic flow also. So clinical findings, CT scan. CT scan is the gold standard for diagnosis of subarachnoid hemorrhage. Here in this CT scan, we can see the white hyperdense blood everywhere in the brain. It is seen in the interhemispheric fissure, in the sylvian fissure, around the basal cistern, around the brainstem, like perimesencephalic cistern. This is a classical diagnosis of subarachnoid hemorrhage. The white hyperdense bleed that is seen in the sulci, it is seen in the fissures, it is seen around the basal cistern. So this is classical finding. It is difficult to diagnose subarachnoid hemorrhage on MRI because it is confusing. So CT scan is the gold standard investigation of choice. So if there is a clinical suspicion of SAH is high, but CT scan is negative, means there is no blood, then go for lumbar puncture. In the lumbar puncture, we remove the CSF and we send for analysis. In that, we see xanthochromia, means yellow tinge CSF, and numerous RBCs are there. Then it is confirmative of subarachnoid hemorrhage. What are the complications of the subarachnoid hemorrhage? The most dangerous complication is rebleeding, means aneurysm again bleeds. That is very common within 24 hours of first bleed. So other is next common important complication is vasospasm. This is between the 3rd to 14th day of main bleed. And a third important complication is hydrocephalus. What is vasospasm? Vasospasm is narrowing of the arteries in the subarachnoid space due to presence of the blood in the subarachnoid space. It is typically seen between the 3rd to 14th day of primary bleed. What does it do? The vasospasm, because narrowing of the arteries will be there, leading to delayed ischemia, cerebral ischemia, and neurological deficits. So, how to manage this subarachnoid hemorrhage? Initial stabilization and to prevent complications. So, in order to prevent rebleed, we need to reduce the BP to less than 160 mmHg, systolic blood pressure. If the blood pressure is high, it may lead to rupture or rebleeding. Other thing is Nimodipine. It is a calcium channel blocker. It is vasodilator. This is given 60 mg 4th hourly to prevent vasospasm. This is vasodilator drug. So it prevents vasospasm. Seizure prophylaxis is given to prevent seizures in the form of many anti-epileptics are there. And the best one is levetiracetam. And how do you treat hydrocephalus? Hydrocephalus is excess CSF accumulation in the ventricular system. So we need to drain or remove the CSF we put an external ventricular drainage EVD. In that, we put a shunt tube in the ventricles and we drain the CSF outside. Why we are draining outside? Because the blood is there in the CSF. We cannot do ventricular peritoneal shunt or VP shunt. They get clogged. They get blocked. That's why we temporarily exteriorize. We put a drain and we drain the CSF outside till the bleeding clears. So definitive treatment is either by surgical clipping or endovascular coiling. In surgical clipping, after doing craniotomy, the titanium metal clip is applied across the neck of the aneurysm. This is the aneurysm. It has a neck and it has dome. So this titanium metal clip is applied across the neck to exclude the aneurysm from the artery. So what are the indications of surgical clipping? The patient is young and if the neck is very wide, surgical indication. If the aneurysm is distal like MC aneurysms, it is surgical indication. What is coiling? It is endovascular coiling. Here the catheter is passed into arteries, either the radial artery or through femoral artery, and the catheter is inserted into these aneurysms and balloons, metal balloons, coils or metal coils, they are passed into this one aneurysm sac. This aneurysm is excluded from this one. When do we do coiling? If the patient is very sick, unfit for surgery, then we go for coiling. And if the aneurysm in the posterior circulation, like basilar top aneurysms, this is preferred coiling. So this subarachnoid hemorrhage has very high mortality. So early treatment, aggressive treatment of vasospasm, aggressive treatment of hydrocephalus, aggressive maybe either a definitive treatment of craniotomy, a clipping, or coiling. This improves outcome. There is a rule of third in SAH. So when we treat the SAH people, 1/3 here, 1/3 they will die before reaching the hospital because of the massive bleed. Even they don't reach the hospital. 1/3 of SAH patients, they survive after treatment, but they have some residual disability will be there, like neurological deficits will be there. 1/3 they recover very well. So we need to treat aggressively this subarachnoid hemorrhage. You can watch my old videos like on EDH, SDH, hydrocephalus. If you found this video very useful, please like, share, subscribe. Thank you.